Today we're in Greenville, South Carolina, in the offices of Dr. Frank Wrenn. As many of you know, Frank and I are old friends of many years' duration. Frank has had an unusual career in neurosurgery. Trained at Duke, coming to Greenville, and beginning a practice here. Frank has served on the American Board of Neurological Surgery and has served as president of the American Association of Neurological Surgeons. He's a member of the American Academy of Neurological Surgery and has been the subject of a number of other activities. He currently is extremely active in the nationwide EMS survey, and I'd like to ask Frank to begin this interview by telling us a little bit about his involvement with the EMS.
Well, first let me say that I'm sort of astonished that you're here to interview me because knowing of some of the other interviews that you had, I don't consider myself in that class of people at all. To answer your question specifically about the emergency medical services, I think really my interest in that began during the time that I was on the Washington Committee, and we were involved in some of the various considerations about how neurosurgeons should be involved in the management of trauma. And when the opportunity was presented to me to represent neurosurgery on the AMA's Commission on Emergency Medical Services, I accepted that as a challenge, and from that I think it's fair to say that I've learned a great deal about the subject of trauma itself, but also have had an opportunity to look at the necessity for the organization of surgical specialty services as they relate to trauma, most specifically to neurosurgery. I think it's fair to say that when I began my term on the AMA's commission, that in the eyes of many trauma surgeons, particularly those who'd been active in the American College of Surgeons Committee on Trauma, that neurosurgeons were viewed as something of the pariah. This was shortly after there had been a lot of concern in the grassroots of neurosurgery about meeting college standards for prompt appearances in the emergency room and other things of that nature, all of which neurosurgeons, I think, correctly questioned and correctly entered into with some degree of caution. Now, I think some 5 or 6 years later, I've seen that situation turn around until neurosurgery has taken a very responsible position, I think, thanks to the leadership of the AANS and of the Congress and of the Joint Section on Trauma. I think my perception is that neurosurgeons are viewed with a great deal more respect by their trauma surgeon peers, and some of the other surgical specialties are beginning to receive some of the criticism that we received some years ago.
Let's turn the subject to a slightly different one, and that is, when you came to Greenville, what was it like here in neurosurgery at that time?
Well, when I came to Greenville 33 years ago next week, in fact, this was a community which had a substantial reputation in this part of South Carolina. It was one that I felt that I'd known something about, but when compared with the university center that I had left in Durham, there was a lot of development to be done. Even though another neurosurgeon had preceded me by several months here, neurosurgery was decidedly in its infancy, and shortly after I arrived, I was the only neurosurgeon between Charlotte, 100 20 miles north of here, and Atlanta 150 miles south of here. There was a great demand for neurosurgery, and what I found was that I was so busy working 16, sometimes 18 hours a day, 7 days a week, that there was very little time left to think or to accomplish any of the other good things in life. I think that over the years, as there have been an increasing number of neurosurgeons in this region, work habits are considerably different, although in having gone from 1 to now 14 neurosurgeons in the same region, I find that we're all still busy, although not at the same level of intensity that I recall a lot of years ago.
Will there be more neurosurgeons move into Greenville, you think?
Unquestionably, I think so. You'll recall that prior to 1970, you and I were much interested in the neurosurgical manpower considerations, and one of the conclusions that we reached was that demand forecasting for neurosurgical services was extremely difficult to predict, and I think that our current experience is commensurate with that.
Yes. I think that we're going to see a greater demand for neurosurgery as the population median age approaches the age when the major neurosurgical diseases occur. I still think the thing that we're most involved in now is trauma and spinal disease.
There's no question but that's so here. It seemed to me when I first arrived in this part of the world that I was absolutely inundated by trauma. I was surprised that I did not see the amount of spinal disease that had been a part of my residency training, but that gradually has changed over the years, so that spinal disease is a great part of what I believe the community neurosurgeon does these days.
Certainly is.
I think we've seen that in several different mutual experiences that we've had.
Sure. And one thing that bothers me a little bit is that spinal disease requires, in my view, a substantial amount of insight into the patient that harbors that disease. And in the training programs, many times the mechanism by which one gains that insight takes place outside of the training program. And the patient sort of arrives, if you will, with a dotted line and a signed op permit.
I don't think there's any question about that. I think that the neurosurgical training programs as they are presently operating give very good technical expertise about disc removals, the management of some parts of the trauma of the spine. And I presume that it's so in at least some of the training programs that there's an increasing emphasis on the major instrumentation for spinal disorders that have become so much a part of those people who do a great deal of spine surgery. And I think that it's important that neurosurgeons learn those techniques and that they be able to apply them to the cases that are sent to them for their care, because after all, spinal surgery involves a very important part of the nervous system, both the central and peripheral nervous system. And there are many techniques that I think those in other specialties have evolved that it's incumbent upon us to know these days.
One thing I also would like to ask you is about your training at Duke with Dr. Woodall and Dr. Odom. You stayed there, I think, an extra year, didn't you, to work on positive admission isotopes?
I think it's reasonable to say that when I arrived in Durham for training, the neurosurgical program was in its infancy. There had been a period of time when the manpower, house staff manpower for the neurosurgical service had as it had been at Hopkins, which was the progenitor of the Duke training programs. That the neurosurgical manpower from a house staff point of view was provided by those rotating through the surgical residency program. It had been during the time that I was away in the service that the program had become formalized, and then Don Matson had been there for a year, and the people had been taken into the program with a view towards creating a 4 to 6 year program. And it was Dr. Woodall's idea that his neurosurgical trainees should all be grounded in some part of laboratory experience, since he, I think, recognized that one of his missions should be the training of academic neurosurgeons. He arranged these. It happened that I was fortunate enough to have been the recipient of an Atomic Energy Commission fellowship, and I spent 2 years in the laboratories working on a project that involved the use of positron-emitting radioisotopes, which we hope would be useful in the localization of brain tumors. As it turned out, it was not the most useful technique in that regard, but other applications have been found for it in subsequent years.
Yes, the SPEC machine has been widely used across the country to measure and do a lot of interesting things.
Yes, it is.
And
but if you're asking me a bit about my experiences with Doctors Woodall and Odom, I can only say that they had an immense influence on my lifetime. Dr. Woodall was a very charismatic person. He was the possessor of an incisive mind. He possessed a precision of speech which was exemplary. Sometimes the precision of his speech was painful. But I can't say enough about Guy Odom, because I think that there's nobody in the world who ever meant any more to me than Guy, for a world of reasons. He was a great friend, he was a great teacher, he was a great inspiration, and he was a great leader for neurosurgery. If you look back upon the things which began during the time that he was a dominant figure in neurosurgery, you recognize what an immense influence his leadership had.
quite correct.
And I think that the boundless affection exhibited by his peers is the sine qua non of
Exactly. The Duke training program is also unique in that it formed a club of the former residents called the Owl Club, Odom Woodall Legion. Does that still meet every year?
Well, it's interesting that you should ask that, because I just this morning received an invitation to this year's bi-yearly meeting. It's as other neurosurgical training programs have done, the idea of gathering to honor your former chiefs is relatively popular, but I think that the Owl Club, the Odom Woodall Legion, has been a bit unique. We've always had a sense of closeness, I think in great part a tribute to Guy and the immense affection that we all had for him.
Yes. As you've seen this community grow medically, has it remained sort of the medical center between Durham and Atlanta?
Well, of course, that I don't think I would quite say that, because certainly Charlotte has been an extremely progressive community and has been an extremely progressive medical community. I think in some ways that Greenville and Charlotte are similar, although I don't think that we have quite the breadth that perhaps exists in a place like Charlotte or in Atlanta, but certainly Greenville represents a major tertiary center for the area between Charlotte and Atlanta.
Do you know what? Excuse me, go ahead.
Well, and I think that we've been fortunate in this community to have had a relatively forward-looking hospital administrative group who put together nice facilities. Our problem is not locally one of facilities as much as it is a problem of program development at the present time, and I think that'll come.
All specialties are represented here?
Yes. The sole exceptions to that at the moment would be a pediatric endocrinologist, which is not, especially not relatively,
Not a very common specialty.
not a very common one, and it's not available in many places. I don't know of any of the adult specialties. We do not do pediatric cardiology, at least at an invasive level locally, and we have no pediatric cardiac surgical program. But all of the other programs are in place.
Mm-hmm. What do you see, Frank, down the road? Where do you think neurosurgery in South Carolina or in the nation will be in, say, 20 years?
Well, I don't think neurosurgery is going to be any different in South Carolina. My hope is that it won't be any different than it is anywhere in the world, because I've constantly felt that one should strive to create the best kind of program one can create in one's environment, and that means, in my view, that which is done anywhere in the world. I don't know that that's totally achievable, but at least I think that ought to be the goal. I think that we're going to find that there are going to be continuing changes in the way we manage certain disorders, for example, movement disorders, something in which you're currently greatly interested. I think that there will be improvements in spine stabilization. I don't know what's on the horizon with respect to the restoration of damaged neurological tissue, but I'm sure something is there. I don't know. There are many times that I've thought how interesting it would be to be here 20 years from now and to see what the world is like.
It'd be interesting if you had a 20-year hiatus and you were here and then you were there 20 years later, not see the development as it goes along.
Yeah.
It's sort of like, you know, that expressway has always been there, but you know it hasn't always been there, but you were there when it was made, so it...
That's true. The other side of the coin, of course, is that we're talking about, you know, scientists. The changes that occur in the practice of neurosurgery as a consequence of science. The other aspects of the practice of neurosurgery as they are affected from a socioeconomic point of view, I'm not so happy about, and I don't know that I'd really want to be a part of it 20 years from now if it goes the way the last decade has gone.
Can you be a little more specific about that?
Well, I think that I'd say first, I don't think there's a thing wrong with the idea of public accountability. I think that's a part of our societal responsibilities as physicians. The extraordinary degree of scrutiny to which our profession is frequently subjected it can in some ways be healthy. but sometimes I think it gets out of perspective. We have a lot of talk about quality and quality assurance. I'm not sure I know, or anybody can tell us exactly what quality is. This week's Journal of the American Medical Association has a very thoughtful essay about that, in which I know that I spent a lot of time myself in peer review and in quality assurance, and I know that as I do chart reviews, I'm often wondering not only whether or not this particular chart truly reflects what happened in that particular case, but I've wondered what it is the patient thought.
Yeah.
And
that's a very vital part of the assessment process, which is totally missing.
And you and I spent a lot of time together talking about how one assesses the quality of neurosurgical care. Well, I think when we talk about quality, we talk about whether you're satisfied with the outcome, and you talk about whether it's efficiently done. Where the problem arises is in the disputes that occur over money, and the tendency of many third-party people to view quality as
A dollars and cents issue.
a dollars and cents issue, and we see that reflected in so much of what we do these days in our dealing with third-party people, from the federal level down through the health maintenance organizations, which are burgeoning in various parts of the country, although I don't know many HMOs at this moment that are not without some problems.
That's certainly true in Texas. Are there many HMOs here in South Carolina?
Yes, well, there are not many, but we currently operate with 3 in this community, but the principles of pre-certification for admission, of pre-authorization for invasive procedures, and of all kinds of authorizations, and dealing with the reimbursements that are a part of the ways in which patient care is funded these days have created a lot of difficulty. And another part of that set of issues is the tendency to view medical liability as a part of the quality control issue.
Which it really is not.
No, it's not at all. And that's a very formidable problem for many of us in high risk specialties such as neurosurgery. We take tremendous risk on behalf of our patients, and sometimes what we do doesn't yield a satisfactory outcome. Not through any fault or mistake, but it's the nature of what we do.
We don't treat the measles. One final question. I know you love to play golf, and I know that you were instrumental in the development of the Chanticleer Golf course here in Greenville. What would you say was your favorite golf course? Chanticleer?
Well, no. Kemp, as you know, I don't live very far from Chanticleer Golf Course, and I did have a little something to do with it, though not much. It's certainly one of my favorites, but I think really of the golf courses that I've played here in the UK, that I would list Pebble Beach, something close to your heart, and probably Royal Dornoch in the northern part of Scotland, which is just an absolutely magnificent venue for golf if you want to deal with golf at its basics.
Thank you very much, Frank.
What a nice question to end an interview about.
I have a question, if you don't mind, something I've been very curious about. We can edit this out if it's I'm sitting here with 2 very, very prominent neurosurgeons. One of them found your prominence in academic medicine and yours in private practice. Very few people who reach your level of prominence have come up through private practice. Do you feel that that has been an advantage for you or a disadvantage, or how would you compare that, and why didn't you get into academic medicine?
Well, I think I'd answer that question this way, Bill, that my original goal was an academic job, but for a variety of reasons I ended up here in Greenville, and I really consider it to have been one of my great privileges to be able to experience both sides of the street. I've known what it has been, what it has meant to be a community practitioner, and to become involved heavily in the medical affairs of my community. But at the same time, I had worlds of friends who were in the academic world, and they've all meant a great deal to me. And I think that the fact that I became the president of the AANS really is a reflection of my friendships and of the political process, if you will, rather than anything that has to do with my prominence as a neurosurgical practitioner.
So it has something to do with a word which is often misused, and that's called ability.
Well, sometimes I think I'm really have been awestruck by some of the things that have happened to me, but it's been a great privilege.
Thank you very much.
Thank you.